Almost escaped us.
Okay, now you're going.
Okay. Well, I just want to first off, thank you for your patience tonight. I know that we're running behind, and I'm aware that you have got a 7:30 hard stop. So let me just take this moment to introduce you. This is the Board of Directors of Buffalo Programs. And Patrick Gaudier is with an organization called Advocates for Human Potential. This organization, and specifically Patrick, is highly sought after by the federal government and by states and all manner of provider organizations as an expert on the implementation of healthcare reform. With a real, I think a specific, I don't know if you would market yourself this way, but a real specific expertise in the integration of behavioral health care and how healthcare reform is influencing how behavioral health care is designed, delivered, and financed.
Sounds good.
Okay, and I will let you all introduce yourselves to him, if you will.
Oh, I just did. I'm Ms. Williamson.
Hi, Judy Kramer.
Hi, Judy.
Doug Brown.
Ralph McLaren.
Hi, Ralph.
Margaret.
We met, Mark.
We got Dave Green,
Hi, Dave.
Tech.
Guru.
Guru, right?
Geek.
Some Myers.
John Curtis.
Hi, John.
Ed Walsh.
We met. All right, good. So I know at least half of you already. Good deal. So let me go ahead. I won't say too much about myself. I think I let the group upstairs know. I've worked as a provider, and I've worked to build a managed care organization in my past. Ran a managed behavioral health care organization for about 12 years, and I've been consulting for 11 years. And so that's 28 years of fiddling with this stuff. And as we were talking about in the hallway, what's happening now is happening at sort of breakneck speed, and it's a unique opportunity. And it's an opportunity that has some risks, and an opportunity that may in fact be a crisis for some people, and an opportunity that may be a fantastic opportunity for other folks. And I think what it boils down to, particularly at this juncture, because we are, you know, the Affordable Care Act is some years old now, 6 years old, that at this juncture it's about decision making and making some strategic decisions, and I think making those decisions based on some understanding, and that's what I hope to bring. You know, we've got an hour, and if in an hour we can pop through the materials I've prepared for you, you have them, so I don't want to read them, please. We can help it death by PowerPoint. But I do like to give people lots of information, because it's information that enables you to make decisions. And if you forget something, and you can go back to this packet and say, what was it that he was talking about? And I want you to be able to have it. And if you don't have it, and I want you to be able to call Cindy, and Cindy can say, do you have something more about this particular topic? And I'm a pretty fanatical librarian and archivist when it comes to this stuff, because I feel responsible for knowing it and for sharing it, hoard information. So that's why you have 52 slides. And I want to start with trends, and because I think it's important for people to know, first off, on a high level, what's happening, what's going on. We hear about all this healthcare reform, and unfortunately, most of what we hear about it, we hear about it on television. You know, we hear Hillary and Donald duking it out, or Bernie Sanders and Hillary arguing over Cruz and others talking about it on TV. And is that really what's happening? What's happening? And it's such a complex sector. And just to my own sort of personal opinion about the healthcare sector in general is it's at the intersection of a whole bunch of sectors, whether it's economics and finance, or law and science and biotech and social policy and education and research, and it's massive. So to be able to stay on top of the healthcare sector at all is difficult for the vast majority of people. But then to throw into the mix all the rhetoric on TV, it makes it very difficult to keep track, and to keep track in the midst of radical change. This has been a revolutionary few years already. The Affordable Care Act won't be fully implemented until 2020. So we're partway there, and the part way that remains, what do we do with that? And I think that's the question for you all, is what do we do now? We know that there's still time, not a lot of time. 2020 is 3.5 years down the road. But what's our best strategic direction? So the trends, I think, are important to understand. And the first one is that what's happening around the country is a trend toward, in a very rapid clip, I'll add, to organize and integrate delivery systems. And delivery systems is a fancy way of saying all of the healthcare and social services constitute delivery of services and care to people, but to create systems instead of what we have today, which are silos, right? And there are all kinds of analogies. Upstairs we were using pup tents and big circus tents and that people can come under. But the idea is, and I think it's the sort of the shorthand way to help people understand, is if you're well familiar with Kaiser, then you're familiar with the blueprint for where we are and where we're going. That's the idea. Kaiser, the model Kaiser, they actually use two others, Geisinger Clinic and Cleveland Clinic, which are both very similar to Kaiser, although much smaller. They represent the objective. That's the aim. We're in the midst of creating Kaisers all over the country. Okay. So what does that mean? It means we've hybridized the payer and the provider. Payers and providers have always been at odds. They've always been two completely separate camps. One holding all the money saying, no, you can't. The other wanting all the money saying, yeah, but this person's really sick, we need the money, and we're gonna provide as much volume as we can to make our nut. And so that creates the tension that we all know exists between insurance companies and providers, or payers of any kind of providers, is, look, time out, we have a finite budget, you've gotta stop providing services, and we can't because the demand is so great. So these organized delivery systems are not just meant to organize the providers, they're meant to organize the payers and the providers. And we're gonna talk about some real life examples of that here in California. See them not just as a big circus tent that everyone gets to play under, but they're really joint ventures. So it's a new business entity that gets created in the process, and people own a piece of that business. So if Anthem Blue Cross were in the room, they would tell you about all of their joint ventures. They're doing this all over the state. They're working in partnership with providers to build these systems. The other trend is toward making those systems as community-based as possible. Just sort of a nice way of saying it's got to be local and designed for local parameters and local sort of requirements. And it's another way of saying, if we don't need to have people in an institution, we'd rather have them in the community. Largely because it's cheaper. The economists tell us it's in our best interest to move them out of the hospital and into the community. But it just so happens that the people tell us they'd rather be in the community too, right? So it's actually kind of a win-win situation. The other thing and it's not so much a trend as much as a really critical point to make, is that a lot of the design effort right now is around people with multiple chronic conditions, because they represent more than 2/3 of our spending. Okay? And a lot of organizations like yours, when you either look at your own data or gather the data, you find out that you're already serving people with multiple chronic conditions. So put your business hats on. This is a business discussion, so I'm gonna say things that are gonna sound awful from a humanitarian standpoint, but this is not a humanitarian conversation. That's not why I'm here. We can come back to that later, but I put on my business person hat and say, if I've got the people that these systems are developing to treat and serve, then I have something that has value. I have the people, and I have bucket. I've got this whole 35-year-old, 40-year-old, how old's the organization?
Almost about 45.
45-year-old institution, really.
70,
So you've got this history, the community knows you, you are community-based, you've got the people, okay? And that focus on chronic conditions means that there's a constellation of medical conditions like hypertension, cancers and whatnot, that are very, very expensive overall to our system of healthcare financing. And almost always, there's a co-occurring mental disorder, mental health disorder, or co-occurring chronic addiction. The rate of comorbidity is very, 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 very high, like 85% of the time. So the behavioral health angle is really important, because we have the people, we have the services, we're in the behavioral health and social services space, we're in a good position. Right now I'm holding, every time I look at this list, I'm holding more and more cards. The other trend is toward patient engagement, because we can build the systems and we can change the way things are financed, but if we don't change the way we engage patients in their own behavior change, then we're really not gonna get anywhere, right? So we need to, things like the way people eat, the way they smoke, what they put in their bodies, the way they drink, whether or not they get any exercise, and somebody upstairs called, well, that's wellness. Yeah, it's wellness. So wellness is in patient engagement in treatment, so people follow an actual course of treatment, which they don't always follow, which is why we have an opiate epidemic, right? Why diabetes sufferers tend to suffer more than they need to, because they are non-compliant with their treatment program. So do people like yourselves and the people who work for you, who have a specialty in managing behavior and helping people who have difficulty self-regulating, do you give a card to play in the patient engagement realm? Of course you do. That's what you're doing all day long, is teaching people how to regulate, how to do things that are healthier for them in their own self-interest. And you've developed, the behavioral health care field writ large has developed a whole compendium of best practices around managing behavior. It's a wonderful opportunity. Because managed care companies, with the exception of Kaiser, who spent 100 years figuring this out, Anthem Blue Cross, for example, is not in the business of patient engagement and wellness, and that. Now they're getting into it, but that's not their history. They were an insurance company. Hospitals, they treat acute symptoms, get people stable, and then go on to the next one. But it's providers like yourselves that really hang in there with people through their lifetime, you know, and make a commitment to families and community. So you play an important role in that. And this is not something the behavioral health care field is trying to accomplish. This is something the federal government is trying to accomplish. And it's mandating, all these bullet points are mandated across Medicare, Medicaid, commercial health insurance, the whole gamut. Because if we don't figure these things out, we continue to spend $1 in $5 in this country on healthcare, which economists will tell you is one of the reasons why we can't compete globally in a lot of different respects, and why we've had to offshore jobs. And so now that, all that's debatable, but you can't debate $1 in $5 being spent on healthcare, which is at a clip 3 times that of other industrialized countries, is totally unsustainable. It doesn't work. And we can be part of the solution. And that's what we're actually being invited to do. We're being asked, please bring your special savoir-faire to what it is we're trying to accomplish so we can accomplish it. Because without you, it won't work. The other trend is toward value-based reimbursement. Value-based reimbursement moves us away from volume-based reimbursement, right? So we've heard this dialogue, I'm sure. And value-based, and we'll talk about value, the definition of value, but value-based reimbursement is essentially that you're gonna produce better outcomes, much better quality, much better and transparent patient satisfaction. And if you can do that at a lower cost, then you can keep the savings. But managed care circa 1980 was, all you had to do was put the screws to all the services and you made extra money. Well, you can't do that anymore by law. You have to spend 85 cents of every dollar on claims. Everybody does. So it's a whole new era. It's a different kind of managed care, and that value-based reimbursement is applicable to everybody. Everyone now in this organized delivery system, okay, think of it as that Kaiser model, is going to be reimbursed on the basis of the outcomes they produce, the quality they produce, the satisfaction they produce. And if there's any money left over, then they get to keep some of that money. That's a whole different business model than ever before, unless you worked for Kaiser. For everybody else, it's new. Of course, because it's such a big circus tent, we've organized a delivery system. It's a focus on meeting the whole person's needs, and we'll talk some more about that. But you have to meet the whole person's needs, because if you just treat them in the hospital and you don't do anything about the fact that they're homeless, they're gonna be back. And now Medicare is fining hospitals for readmissions. Hospitals are getting fined. It's unheard of. They're readmitted within 30 days, here's the fine. Readmitted within 90 days, here's a lesser fine, but a fine nonetheless. So hospitals have a vested interest in not having people readmitted. 5 years ago, they didn't mind readmissions, right? Because it was another payday. So this focus on what is it that keeps people coming back to the hospital? What is it that keeps people so sick